it's my honor to introduce Dr. Fong and Jesse. Dr. Carmen Fong is the co-medical director of Hemorrhoid Centers of America in Atlanta, Georgia. Previously, she served as an assistant professor of surgery in the Division of Colorectal Surgery at Mount Sinai Hospital in New York City. She is the author of Constipation Nation, a book that brings humor and humanity to bowel health and surgical care. Dr. Fong earned her MD from Michigan State University College of Human Medicine, completed her general surgery residency at Mount Sinai Beth Israel, and a colon and rectal surgery fellowship at Stony Brook University, NYU Winthrop. She currently serves as chair of the Outreach Subcommittee of the Young Surgeons Committee of the American Society of Colon and Rectal Surgeons, a reviewer for surgical endoscopy, and serves as medical advisor for Fight CRC, Lumina Medical, and Polari Group. She is also chief medical officer at BUMmed, a digital health platform for anorectal care, and was an OpMed fellow for Doximity from 2022 to 2024. Her writing appears in Substack, Kevin MD, and Baseline MD, where she advocates for patient-centered care and surgical innovation. And Jessie Wong is a registered dietitian nutritionist and founder of Joy Nutrition Consulting, PLLC. She specializes in gastrointestinal nutrition and functional bowel disorders. She serves as vice chair of the GI practice group DIGID of the Academy of Nutrition and Dietetics, where she advances professional education in digestive disease nutrition. Jessie is also the host of the IBS Nutrition Podcast, an evidence-based show featuring expert interviews and clinical discussions on gut health, and the creator of Poopedia.org, an educational platform dedicated to improving bowel health literacy for both clinicians and patients. Through her teaching, writing, and leadership roles, Jessie helps bridge the gap between clinical research and practice in the evolving field of digestive nutrition. And so with that, please take it away.
Hi, everyone. Thank you so much for joining us today to learn about GLP-1, GI side effects, and how to better help your patients manage their nutrition and intake. We do not have any disclosures for this presentation. Dr. Fong is supposed to kick off the meeting. However, she is still seeing patients. She will be a few minutes late. So we are going to jump ahead to go to my slides to talk about nutrition strategies for common GLP-1 GI symptoms first. Okay, so I'm going to go through some of the nutrition GI strategies for GI adverse events, which is very commonly reported side effects associated with GLP-1 receptor agonist therapy, particularly during dose titration stages, especially during escalation phases. So symptoms such as nausea, constipation, bloating, and these can all impact treatment adherence and also patients' quality of life. So in the next few slides, I'm going to go talk about that first, and then we'll go back to Dr. Fong's slides to talk about GLP-1, the statistics and titration. All right, so the next few slides, we're going to share evidence-informed nutrition strategies that healthcare professionals, including dietitians, prescribers, and nursing staff, can apply in clinical practice to help mitigate the effects, the GI side effects of GLP-1 and support ongoing therapy. Now, nausea and early satiety are among the most frequently reported side effects of GLP-1 receptor agonists, driven by delayed gastric emptying and slowed upper GI motility, both of which are dose-dependent physiological effects well documented in GLP-1 clinical trials. And here are some nutrition strategies to help support your patients. So encourage smaller and frequent meals. And the goal is to reduce gastric distension and improve tolerance by lowering the volume per gastric contractions or per meal. And then we find that in research, lower fat and more bland meal tend to empty more efficiently than higher fat or spicy food, which can prolong gastric retention and increase nausea. And another interesting things I think most GI dietitian would know is that cool or room temperature foods tends to be better tolerated because they have reduced food odor, which can sometimes increase nausea and maybe induce some vomiting in patients who have very heightened GI sensitivity. Now, a big one I want to mention is hydration. Hydration is, of course, a key factor in maintaining life and everything in life, and we always try to encourage more hydration. However, with GLP-1 cases or with nausea, early satiety, or even with vomiting, we want to encourage patients to hydrate between meals rather than with meals to reduce the gastric volume load again, and hopefully can decrease the postprandial nausea. And other adjunct options that you can try with your patients are ginger, peppermint, or even prescribed medications if symptoms persist despite dietary modifications. Ginger and peppermints, they can do it via tea, or they can do some certain type of supplements and make sure they are certified. They're third-party tested to be on the safe side. Ginger acts as a prokinetic agent and sometimes can help stimulate better gastric emptying and reduce nausea. Okay, and it is often used in pregnancy, chemotherapy, and also post-operative nausea as well. So it can be a good tool for patients. All right, now let's talk about constipation. I think this is one of the ones that we hear most often. Oh, hello, Dr. Fong, you're back.
I am back.
Well, I am talking about the symptoms, about GI nutrition strategies to manage the symptoms.
Perfect.
Do you want me to continue, or do you want to go to your slides first?
No, please go. Continue. Yeah.
Okay, so constipation again is often reported as a side effect as well. We'll talk about diarrhea next, but constipation is very common. And a recent nutrition analysis, which I'll talk more about later, is suboptimal fiber and whole grain intake among these populations. And I'm going to share more about the Johnson et al. Trial that was released this year in a little bit, because it gives us a full picture of what the patients are eating and how we can really improve their health. But in terms of constipation, what we really want to recommend is patients still get enough fiber to support proper gut motility. And the clinical recommendation includes gradual increasing soluble fiber intake to a target range of 20 to 25 grams of fiber per day. Again, with adequate hydration with at least 1.5 to 2 liters daily. Now, we do encourage more soluble fiber intake to help soften the stool and help things come out easier if patient tends to be more on the constipation side. But meeting the fiber goal is really important, and again, increase gradually, and gradual may mean 3 to 5 grams of fiber increase per, every 3 to 4 days. So don't, if your patient is eating 10 grams of fiber, don't tell them to add more fiber supplements and go right to the 25 gram. It can backfire, it can make symptoms a lot worse. It can make their other symptoms like early satiety, nausea, and vomiting worse as well. All right, physical activity is always important. We know, after eating a meal, going on a walk can help improve gut motility, can help improve digestion. So help your patients create a routine, a post-meal routine to help improve digestion and move things along. And also a defecation routine post-meal can help further support motility, because we know gastrocolic reflex still works in GLP-1 patients. So tell patients to maybe leave some time after meals, maybe especially in the morning, having a good breakfast, and then to leave some time for them to go to the bathroom before they move on with their day. Because when we are stressed, when we're moving a lot, our body may not go to the bathroom, especially in cases where this is a pharmacological induced slower gut motility in some cases. So create a routine with your patient for pooping and also post-meal activities. Now, when increasing or changing dietary needs is insufficient in helping your patient, osmotic laxatives such as polyethylene glycol, PEG, or Miralax can be used under medical supervision. This is a very safe intervention. It draws more fluids to soften the stool to help stool come out easier. Now, diarrhea can also occur in GLP-1 therapies, particularly during dose titration. So the management includes emphasizing hydration, right? We really want our patients to be well hydrated. And if they are having a lot of diarrhea, we may also want to encourage some electrolytes containing fluids to make sure that they are not, getting dehydrated. and adjusting to lower fat food and sometimes maybe even low fermentable carbohydrates, such as lower FODMAP meals, can be better tolerated for patients with diarrhea, because this again reduces foods that are irritating the gut lining.
Yep.
Now, reintroduction of soluble and gel-forming fiber through options such as bananas or oatmeal can help with stool bulking. So the goal here is to help their stool bulk up a little bit instead of just plain diarrhea. But if case persists, you do want to evaluate for lactose intolerance or maybe fat malabsorption. So work alongside the prescribing clinician to assess your patients to see if there are other things contributing to the diarrhea. Okay, bloating and prolonged fullness. Again, it goes back to food maybe sitting in the stomach because of delayed gastric emptying. And again, the recommendation is very similar to the nausea, and that is recommending smaller meals and more frequent meals, and maybe remain up and seated or in the upright position after eating so that they feel better. Things are not coming back up and things may be going down a little bit faster. And maybe short-term reduction in carbonated drinks. And again, highly fermentable foods, like think the low-FODMAP diets, can be helpful in improving some of these GI symptoms. But again, the low-FODMAP diet is short-term, right? You don't want to put patient on it long-term. And movement after meals. And if patient's symptoms persist after trying all the dietary changes, and if the symptoms mimic gastroparesis, it should be evaluated collaboratively with the prescribing physician to determine the need for dose adjustment or further diagnostic assessment. All right. Dr. Fong, do you want to talk? Let's have you go back and then I can come back and talk about the overall picture of nutrition. How about we do that?
Sure. Yeah, that sounds good.
Okay, let me go back up. Okay, I'll let you take over from here.
Okay. All right. Hi, everyone. I'm Carmen. I am so sorry I'm late. Of course, the one morning we do this, I have like 22 patients in the morning and an emergency. But anyway, so I just want to say that I am a colorectal surgeon by trade. I don't know if you guys did introductions already, but I definitely see a whole sort of like assess a whole lot of hemorrhoids, fissures, things that are the end result of constipation and diarrhea. And so I'm not a bariatric medicine or a weight loss doctor, but because I've had to work from the bottom up and kind of figure out like in reverse, like what the problems are with GLP-1 receptor agonists. So we're going to talk about very briefly GLP-1 receptor agonists and do an overview and then talk about the exposure dependent GI side effects. And then as Jesse has already started talking about the prevention and treatment strategies for these GI side effects. Next slide, please. Okay. All right. So GLP-1 are, as you know, naturally occurring peptides. So they're endogenous to the human body. But what we use them for, the actual receptor agonist, is in type 2 diabetes, obesity, and cardiovascular risk reduction. I think if you click right there, it actually says the most common reason we use this medication right now is for weight loss. So I used to tell people that I would see maybe one person on a GLP-1 receptor agonist every 6 months or so. And now literally about half my patients are on GLP-1 receptor agonists. A lot of them will also not tell me initially because of all the different ways that you can get these injections or pills these days. So I have to be very careful to ask to be like, hey, have you had any sudden change in your, GI system? Have you had any change in your bowel habits? Are you on a GLP-1 receptor agonist? All right, next slide. So the incidence of GLP-1 receptor agonist use is actually, this is probably underreported, but most of the recent data says 2% of the US population, which is 6.7 million people. So 6.7 million people are on these weight loss medications. A large percentage of them are on them for chronic obesity and diabetes. But as you know, most recently, people are on it for weight loss. All right, next slide. So the mechanism of action of a GLP-1 receptor, it increases our insulin production, right? And it decreases glucagon. So basically it decreases our blood sugar levels in our body. The GLP-1s also delay gastric emptying and they increase your satiety, which means you feel full faster and it decreases your appetite. I saw a question in the comments already about a motility agent. So the GLP-1 definitely decreases your gastric emptying, but I'll tell you a little bit later why we don't necessarily need a motility agent. All right, next slide. So the approved doses, for example, for Wegovy and Ozempic, which are both semaglutide, 0.25 milligrams to 2.5 milligrams weekly, and it has to be titrated. And for maintenance, 2.4 milligrams for obesity, and 1 milligram for type 2 diabetes. So most people that I see are actually on the 2.4 milligram maintenance dosage because it's for weight loss. So the dose escalation schedule, this is one of the most important things I learned while researching this in terms of how to help my patients who are having GI adverse effects due to weight loss medications, is that there is a dose escalation schedule. So in general, if someone is getting their medication from somebody who's just like prescribing them 2.4 milligrams initially, they're probably starting at too high a dose and they are going to actually have worse GI side effects. You want to start low and go slow, kind of like roasting a chicken. So you're going to start at 2.25 milligrams for 4 weeks and then double it or so every month until you reach that 2.4 milligram maintenance dose. And next slide. So the GI side effects overview. So I'm going to have the incidences of how much of each of this on the next slide, but there is, as you know, nausea, vomiting, diarrhea, constipation. Over 70% of patients have reported some type of GI side effects, including these four, but I'll separate out each of the four. Next slide. So there is an exposure response modeling, which means that the gastrointestinal adverse effects increase with dose exposure. The most prominent by far are nausea and vomiting. That's why I kind of pointed out that dose titration schedule because it does make a difference what dose you are and for how long. Next slide. So in the SEP trials, the adverse event rates were for nausea, 43% versus 16% in a placebo. Diarrhea was 29% versus 15% placebo. Vomiting, 24% versus 6.3% placebo. And constipation, 24% versus 11%. This is actually increased from when the studies first came out. It was almost like a 7% constipation rate, and nausea was about a 14% constipation rate. So I think that as we're seeing more and more patients who are actually starting on higher and higher doses of these medications, we're seeing a lot more of the GI adverse effects as well. Next slide. So in type 2 diabetes, just in case some of your patients might be on type 2 diabetes doses, again, the 0.5 milligrams actually shows lower GI adverse events rates. And then 1 milligram has a modest increase. And then these effects were confirmed in the SUSTAIN trials. Next slide. And so this is actually a generic dose response curve, but I just wanted to show you that, as the adverse events rise with semaglutide, in particular plasma levels, but there is a plateau. So after about 1.7 to 2.4 milligrams, the GI adverse events actually plateau. And so they don't get worse after that. It's just that at that point it maxes out. All right, so again, 0.25 milligrams, low adverse events. 0.5 milligrams, the nausea is about 15%, diarrhea is about 10%, constipation about 5%. And then when you go to the max maintenance dose, 2.4 milligrams, it's for 43% for nausea, diarrhea 29%, constipation 24%. And I know I'm kind of like, repeating this again and again, but it is really the most important factor when considering your, one of the most important factors when considering your GLP-1 patients. All right, next slide. So the higher doses right now are under study, but the GI tolerability is actually a very much a dose limiting factor for patients. About 4.3% of patients will quit a GLP-1 receptor agonist in general, just because of the GI side effects. That's actually kind of a lower number than I thought. I actually thought more people would quit, but the benefits are so great that most people will actually try to stick with it for a while. And what I'm going to show you here is that if the doses are increased appropriately, if we manage everything else with, diet, your nutrition, and then also like some other, adjunct supplements, you can actually manage the GI side effects well enough that you can get the benefits of the GLP-1 receptor agonist and not have to quit it. And next slide. So the constipation in general, since, I study constipation and that's what I talk about the most. Again, 24% on 2.4 milligrams versus 11% in placebo. I think that, again, it was underreported because in prior GLP-1 literature, we also didn't understand things that, if you have decreased satiety, you're actually decreasing your actual food intake, and that can lead to constipation as well. And plus the effects were varied. You would have alternating diarrhea and constipation. And we didn't really know how to look at that. But now that we have a lot more data, we have a pretty good picture. So about a quarter of people will have constipation on a GLP-1 receptor agonist. The vomiting profile by dose, it's not linear. If you jump really sharply and go right to this 1.7 milligrams or 2.4 milligrams, you will actually have a lot more nausea. And again, the effect plateaus at 2.4 milligrams. There are future studies being done at higher dosages of these GLP-1 receptor agonists, but those are not definitive yet. So again, as we know, real world versus trial data is often different. We think that the real world rates might actually be a little bit lower than the data rates because of the reporting. At the same time, I think there is like this like selection bias and randomized controlled trials versus real world patients. So I would say it probably evens out in the end, that a quarter is about right. A quarter of people have constipation. So this is again repeating that about 44.3% discontinued due to GI adverse effects, and most patients will tolerate it with proper titration. All right, so a start low strategy. Adherence depends on GI tolerability, and use the lowest effective dose and titrate gradually. And this is actually the more important one. So, while you might not be the one who is, actually prescribing these GLP-1 receptor agonists, you can recommend holding the dose at a certain level if the symptoms emerge or if they're worsening. So you can hold the titration. Say that they started a couple of weeks ago and they're like having like really bad side effects. You can do two things. You can hold it at that level and see if it gets better, or you can actually just go up to the next dose and kind of push through it. Obviously, if they're much, much worse, you would maintain the current dose for 2 or 4 more weeks until the symptoms improve. Eventually, the body does get used to having the GLP-1 receptor agonist in the body. And so your bowels will compensate. Next slide. So I know that Jesse's already started this part, but, just as an overview of managing the adverse effects, we talked about hydration, intake of soluble fiber. Magnesium supplement is actually the third line in terms of hydration and fiber and magnesium supplement. And then afterwards, you would use things like Miralax or an osmotic laxative as needed. Things that I would throw in there are consider the dosage of the GLP-1 receptor agonist. And then, very importantly, checking other medications with similar side effects. So if you're a clinician or someone who is looking at the medication list, you definitely want to consider that some of the other medications might be compounding the side effects. So for example, if your patient is, recently started on GLP-1 receptor agonist, but also on metformin, uncommon, but metformin has a high incidence of diarrhea, for example. So you would want to make sure that you could, cut down on the metformin. Or if your patient was on a constipating medication, such as an opioid, pain medication, or even something very common like Pepcid or Tums, which has some incidence of constipation, you would want to make sure that you can adjust for those as well. All right, and I think this is where Jesse jumps back in.
Hi, thank you. Yes, we've already went through a few of my slides. For those of you who might be joining a little bit later, you can review it. Everything is in the PowerPoint, but I want to go to talk about protein and macronutrient guidance. So during pharmacological mediated weight loss, protein intake is critical for preserving lean body mass. And the current evidence suggests a targeted protein range of 1.2 to 2.0 gram of protein per kilogram of body weight per day using adjusted body weight. So in 2025, Johnson et al. Paper indicated that only 43% of patients achieve even the lower threshold of the 1.2 grams per kilogram per day eating enough protein to maintain lean body mass. So this is an area that we really need to pay more attention to. Furthermore, patients show a dietary pattern categorized by elevated fat intake, insufficient fiber intake, and a diet with high refined grain consumption, which is all alarming when we are helping patients to decrease their body weight and causing a caloric restriction or decreased caloric intake to maintain weight loss. We need to make sure patients are eating nutrient-dense foods and not foods that tend to be higher in saturated fat, refined grains, or sodium, which I'm going to show you the breakdown in a little bit. All right, so this is the Johnson et al. Study that examines how adults on GLP-1 receptor agonist therapy are meeting their nutrient needs. So despite the proven weight loss efficacy, right, there has been inadequate attention to addressing nutritional concerns, especially during rapid weight loss stage. Plus the GI side effects we talked about earlier, it all became a barrier for patients to maintain a healthy diet to promote optimal health. So this study's objective was to assess whether individuals who's been on GLP-1 medications for at least 1 month are meeting the dietary reference intake, the DRIs, for their nutritional need. So to do this, the researchers collected a 3-day food record in a series of demographic and dietary questionnaire from 69 adults across the US. This is a smaller study, and the authors also said that this is one of the first studies that look at dietary patterns for patients so that we can have better tools when we are helping with our patients. And the participants completed online surveys, logged their food and beverages consumed over 3 consecutive days. Then the researchers compared actual food and nutrient intake to standard recommendations. They also did some adjustments to improve statistical accuracy. So here's what stood out in terms of caloric and macronutrient intake. So on average, the intake was about 1,700 calories, 1,748 calories per day. So even though 75% of participants reported they were eating more protein, the data shows that only 43% actually met the minimum 1.2 grams per kilogram per day after adjustment. I know in here it does show that most of them are meeting it, but after adjustment, only 43% of patients met their protein need, which shows that patients are at higher risk of losing their lean body mass as well. And also the discrepancy, between perceived and actual intake. Now, fat intake averaged 40% of total calories and was particularly high in saturated fat. Carbohydrates were below recommended range, and added sugar were averaging 11.5 grams per day, which is below the RI. Now, overall, these results suggest that while caloric restriction is present, it's not translating into balanced nutrition, particularly when it comes to protein and quality of macronutrient sources. And this has important implications for those supporting patients on GLP-1 therapies. Oh, now that we've reviewed the macronutrient pattern, let's also look at the micronutrients and the food groups finding, which really does reveal a bigger concern. So this is my plate here, and you can see that in the smaller circle with no yellow highlights in the background, that is the serving of each food groups that patients are eating. And the ones with the yellow background is based on a 2,000 calorie diet, how many servings of those food groups patients need to have. You can see that patients are falling short on almost all of the food groups. And when we do a 3-day average nutrient intake, and compared to the dietary reference intake, researchers find that widespread micronutrient deficiency were also found, or not deficiency, but insufficiency were also found. Most participants fell below recommended level for fiber, calcium, iron, magnesium, and potassium. along with several vitamins, including A, C, D, E, K, plus choline. Now, two nutrients were especially concerning, and nearly 90% of participants were below the recommended reference intake for vitamin D and potassium. Both of these are essential for bone health, muscle function, and cardiovascular protection. And these deficiencies were also reflected in the food group pattern, like I just said. So participants did not meet my plate's target for fruits, vegetables, grains, and dairy. In protein, they are closer. In protein, it's a little bit closer, but they are still not meeting it. And on average, patients were eating 4.2 servings of refined grains per day, and only 0.7 grams of whole grain servings when you look at the grains group, which they do meet about 4.9 servings per day. There were a few strengths that we do want to point out. Patients are meeting their B vitamin intake, selenium, and zinc. So those are adequate, but they don't offset the broader nutrient gaps we are seeing here. So clinically, the combination of rapid weight loss, low protein intake per kilogram of body weight, and low micronutrient density, it increases the risk of lean mass loss, fatigue, delayed recovery, and long-term nutrient depletion, particularly in patients not receiving nutrition counseling. So one of the really important findings I want to point out is only about 20% of participants had been referred to a dietitian when starting GLP-1 therapy, despite clear evidence that dietary support is needed. So my key takeaway is most adults on GLP-1 medications are not meeting core nutrients and protein needs through diet alone. And in practice, given the side effects that we mentioned, so the GI side effects that we mentioned about, really need more strategic distribution of macronutrients toward fiber-rich carbohydrates, quality protein sources, alongside monitoring micronutrient status, particularly vitamin D, B12, and iron, to make sure our patients are not just losing weight, but staying healthy in the long term. And incorporating a dietitian and medical nutrition therapy in GLP-1 care team early is crucial, not as a last step intervention. So that's my key takeaway. All right, we're gonna go back to Dr. Fong here.
No, thank you for that, Jesse, because like I am a firm believer that, multidisciplinary care is so important, involving a dietitian early and as part of the care team. That was very fascinating. So I'm just going to jump back in here, and actually I had a chance to review some of the 47 questions that were on there. So I'm hoping to answer some of those at the end too, and then throw what other questions you have in there. So what else can I tell you? Back to the higher dose trials. So as we know, the gastrointestinal effects can increase, but they may plateau. The higher doses are really still under investigation. One of the questions that I just saw in there was about holding GLP-1 agonists prior to surgery. So right now, the Association of Anesthesiologists does not actually recommend that you need to hold it. However, the patient should be at a stable dose. All right, so they also shouldn't be like at a super high dose, because at a super high dose they might have more adverse effects, but they should be at a stable dose where they're not experiencing any of the GI adverse effects prior to having elective surgery at least. Right, next slide. Okay, and then what else? There was also this question in there, the oral versus subcutaneous differences. Subcutaneous, but also intramuscular, some of it. No, sorry, I take that back. It is also subcutaneous. So oral semaglutide actually has similar GI adverse effects. One of the differences being that oral semaglutide generally has to be taken daily rather than a weekly injection. And so you might be having the effects more commonly throughout the week, as opposed to like having like a increase at the beginning of the week and then it kind of dips later on in the week as the effect of the injection wanes. Patient education in these cases is essential. I do have a slide, I think somewhere back here, about what we should discuss when we're counseling patients. And next slide. Okay. Oh, last but not least, so there are some label updates in 2023 and 2024. The FDA added an ileus warning. So because of the delayed gastric emptying and the decreased motility, you can have ileus, which is essentially sleepy bowels. So the bowels are just not moving at all. And if that happens, you want to educate the patient on red flags. So vomiting, severe abdominal pain. Generally, with an ileus, you will probably also not be passing stool or any gas at all. And it also generally happens like pretty abruptly. So it'll suddenly stop and they'll be like, oh, I was pooping and it would suddenly stop. Other things that this could be an indication of would obviously be an actual bowel obstruction. So any of these things should send a patient urgently to the ER for evaluation. All right, next slide. So in summary, though, the GI adverse effects are dose and exposure related, and then we manage through slow titration and supportive care. One of the next question I had on there were about 18 questions on magnesium. So, and actually I thought it was really interesting, Jesse, that you saw in your slide, there was like only like a 90%, 90%, they're only getting 90% of their daily recommended value of magnesium after. That's kind of interesting. So the magnesium supplement that I recommend and has been evidence-based and proven most recently in British Medical Journal is magnesium oxide, 400 milligrams a day. So you can take 400 to 800 milligrams. I have had patients ask me about magnesium glycinate, bisglycinate, and even magnesium citrate. You can take any of those. All of those are actually going to be improve smooth muscle contraction. They actually smooth muscle relaxation, pardon me. And so they can improve your bowel function, improve sleep, have some nervous system effects as well in terms of like calming anxiety. Citrate works the fastest. So literally magnesium citrate is one of the options when we need you to do like a bowel cleanse. So it works the fastest, but it can also be kind of like the most harsh. So I don't recommend that as a daily use. Some people will take the natural calm supplements, which are small gummies that are magnesium citrate, and that's okay, but you don't need to take a giant bottle of it. Magnesium glycinate has more of the neurological and kind of like muscle relaxing effects. So far has been shown to not quite have as many of the GI effects as magnesium oxide. And so that's why I try to tend towards magnesium oxide, 400 to 800 milligrams a day. The other thing in supportive care, so there was a question about Senna. So Senokot, there has been a lot of debate about this over the years. And initially, when I started practice, I actually did not recommend it because of the lazy bowel question, because it is a stimulant laxative. But again, recently it's been shown that it's actually fairly safe. It is a natural occurring stimulant laxative. And so it's fairly safe for long-term use if you need to. I would obviously try all of the other management strategies first before you end up on a stimulant laxative. The one that I would try just above a stimulant laxative like Senna is obviously Miralax or any kind of osmotic laxative. All right, next slide. Okay, so patient education. So I think the number one thing, and a lot of times when I talk to patients who are like, oh, nobody told me that I would have GI side effects if I'm taking this GLP-1 receptor agonist. And I was like, really? So I would just say that you should counsel them that GI effects are expected, but most of the time they're transient. And, as your body adapts to the GLP-1 receptor agonist, your body will move through them. Reinforce a strict adherence and side effect plan. So, we're kind of managing the symptoms with all of our, tools in our toolbox, the same things that we would manage other GI issues. So we're doing the fiber, the water, the magnesium, and the laxatives if we need to. And then having like terrible side effects, like some prescribers will just prescribe Zofran for the nausea, which I think is totally reasonable. And then the peak side effects, again, are during titration, not during maintenance, right? So we know when people come in and they're like, oh, I've been on this for 6 weeks, like the constipation is awful. And I'm like, okay, but what dose are you on? If we can manage, your constipation through this until you're at your maintenance dose, generally those side effects go away. So when people quit is usually that first like 6 to 12 week mark where they're like, wow, I don't know if this is worth it. All right, next slide. So the clinical action items for everybody to have a happy gut and a happy butt. Use a titration calendar. and provide a diet, thanks to Jesse Wong, a diet plan, a bowel plan, and an activity plan. So a sedentary lifestyle will decrease colonic motility, so you want to remain active. Reassure patients that the symptoms are transient. Obviously, if there are any red flags, like send them to, seek, urgent medical care immediately. You want to manage all the other medications that they're on and make sure there's nothing that's compounding their GI side effects. And then again, investigating any prolonged symptoms. So if it is someone who, has gone through the maintenance or is in the maintenance phase and they're continuing to have symptoms, did they have underlying constipation? Did they have underlying colonic dysmotility or IBS symptoms? Generally, I start this almost as soon as they start seeing me, but then the investigation becomes more pertinent when the symptoms are prolonged. I think that I'm going to answer a couple of the other questions here, and then, we can have any other questions because they kind of tie into this. So one of the questions was if tirzepatide has been shown to have fewer GI side effects. So there's not a lot of good evidence out there, but in most people that I talk to, the answer is yes. So I think the answer will bear out soon, but that tirzepatide has slightly lower GI side effects. One of the other things that I read, which is just, not completely evidence-based, but as an aside, where the injection site is might also be a possibility of why things are worse. So injecting near the abdomen might actually have more GI side effects than injecting like in your hip area, for example, right? Because you're injecting right next to the abdomen. But we will see, again, if the evidence bears out on that. Can you preempt the side effects? Absolutely, right? So whenever anyone's considering, starting on a GLP-1 receptor agonist, or, in my practice, a lot of people who are getting pregnant or want to get pregnant, can they preempt this? Yes. If you start on a good diet, bowel activity plan in the beginning, go see a dietitian, and start having your regular bowel movements 1 to 3 times a day, every 1 to 3 days, you will actually be much better off going into it and experience fewer side effects. All right, I think that's it for now, and then we'll see if there's any other questions.
I think there are some questions about fiber. So the recommendation for constipation cases here is 20 to 25 grams of fiber. And there's one question, say, why not just recommend high enough fiber intake? I think that might reference to maybe up to 38 grams per day, depending on which guideline we're using. So it's usually 25 to 38 grams is the higher end. Dr. Fong, do you want to answer that? But my thinking here is that it is adjusted for the caloric intake. So if they are eating lower calories, then they may not need as much fiber. And if they are already constipated, adding too much fiber can make constipation worse and can make them having more other symptoms like nausea or vomiting as well. So that's what I'm thinking. There was a question on sports athletes and nutrition recommendations. So I think this really depends on what kind of symptoms the athlete is experiencing and what are the reasons the athlete is being put on a GLP-1. But in general, if it's for an athlete, we really want to make sure the athlete is hydrating enough, electrolyte as needed. I think the question said the athlete is a runner. So running can really help with constipation. But if the patient is experiencing diarrhea, then we probably want to work on more of the diarrhea strategies, because diarrhea is also a common side effect of runners as well, especially if they're doing something more intense like an marathon or triathlon. Yep. So going lower fat, eating more in athletes cases, pre-game meals, going with lower fat, easier to digest. I think this is the only time we would recommend maybe more refined carbohydrate that is easier to digest, easier to absorb for patients. It's before training and before maybe competition, and maybe even going lower FODMAP as well in those cases, because it again reduces the fiber load and reduces irritation in the gut from the fermentation and or from the osmotic effects, depending on what symptoms the patient is experiencing. But implementing some of the strategies we talked about for nausea can be really helpful, right? Smaller meals throughout the day. If it's diarrhea, if it's constipation, then we might want to do it a little bit differently. So consolidate the meals to increase the gastrocolon reflex. But if it's diarrhea, then we might want to spread out the meals a little bit, going lower on fiber, manage it first, increasing soluble fiber, and then increase fiber again. So you don't want patients to stay on very low fiber diets, but with some very severe diarrhea cases, we might have to go lower on the fiber to let the gut adjust and then try to increase fiber. And if it still doesn't work, that's the time you should probably talk to the prescribing physician to discuss alternative managing.
Thank you both for diving into these questions so preemptively. Fantastic presentation. I'm happy to walk us through a couple others so that you don't have to be speaking and
Okay,
sorting
great.
through these many fantastic questions everyone has. There is one from Mary Lou that's asking more on the older adult side. So for someone over 75, would you recommend Miralax preemptively, or would you handle the older adult differently when it comes to the nutrition assessment recommendations, micronutrients, all of that?
In my case, I would do the Miralax preemptively. Yeah, so Miralax is still safe for an older adult, and actually, many adults as they get older might deal with, more constipation or GI symptoms. And so I would start with a low dose, like a half dose of Miralax daily with plenty of water, and then increase from there so that you are managing the symptoms before you start. Anything you
Yeah.
diet wise?
Yes, I think, for older adults, they are already more susceptible to nutrient deficiency. So I would say, getting a baseline of where their B12, folate, iron, vitamin D are prior to GLP-1 therapy, and then maybe doing an assessment every 6 months if they are at higher risk of nutrient deficiency. Because we know, and of course, assessing the diet, right? If you suspect your patient is not getting enough to begin with, you really want to be testing more often. But this would be something you need to communicate with the prescribing physician to talk about, hey, we really need to monitor this, maybe share the Johnson et al. Study to say that, hey, this is a red flag that we really want to monitor. And with older adults, they can decline a lot faster than younger patients. So we want to stay ahead of the game. Yeah.
Great, thank you both. We're also getting a couple questions around burping, belching as a symptom, specifically also sulfur burps. Wondering if you guys have any recommendations or experience helping patients with that.
I actually cannot say that I have heard of sulfur burps, right? I don't know. I can look into it. You can't have, so I would say that fundamentally, though, you are going to have like somewhat increased bloating, increased gassiness because of the delayed gastric emptying and because of decreased colonic motility. So that's not uncommon. I would say the same things that will work for increasing your bowel consistency is going to help. There was one question in there about psyllium versus Restoralax. Psyllium is first line. So psyllium fiber, in and of itself is both soluble and non-soluble. And so psyllium fiber is going to help soften stools when they're too hard and kind of firm up stools when they're too soft.
Okay. So again, I'm not familiar as well with the sulfur burping, but I'm just looking at some literature, and there may be an increased risk when there's a change in motility. There may be an increased risk for patients to have SIBO, small intestine bacteria overgrowth. And, if a patient is burping excessively, that might be something to talk to the prescribing physician about, maybe getting tested for SIBO and getting treatment appropriately. And again, like what Dr. Fong was saying, dosing can make a huge difference in preventing a lot of this. So monitoring symptoms and recommending dosing or decreasing in dosing if needed.
Great. We have an excellent question from Marty, more on the counseling side. How do you address a lack of appetite, fear of weight regain, especially if they would need to eat smaller, more frequent meals?
I think that's all you, Jesse.
I think again, the lack of appetite is probably from the medication, right? So we want to look at dosing, and if even smaller meals can't be managed, we really want to talk to the physician about adjusting the dosing and maybe go down to a more tolerable dose, like what Dr. Fong talked about, and still maintaining the weight loss or whatever goal that is, for prescribing the GLP-1. Fear of weight regain, and I think this is particularly important to address with patients who are going through weight loss journeys, because this, if it's more extreme, right? If they are not a really big person to begin with, or or if they are very afraid, I think sometimes we might want to involve psych or
Yeah.
maybe a dietitian that is more understanding in health at every size, in providing better care and
Hmm.
telling the patients, it's, weight is only part of the healthcare journey, is not everything. If they regain some or if they maintain lean muscle mass, it's good for them. But I think for us, we really need to look at the big picture and not just focus on weight when it comes to providing better care and achieving, or trying to achieve optimal health outcome, right? Weight is only one number, it's not the full number. We want to look at everything else as well. And patients' relationship with food, if there is a red flag, I think we might need to bring on another specialist to help with the patient cope with the anxiety of eating or the anxiety of weight regain.
Right. No, and I always love when you say that, health at every size. But I would just throw in there that, the food fear is real, but also to counsel at the very beginning that, GLP-1 receptor agonist is just a part of this journey, right? So that, you still have to watch your diet, you still have to, be active, and you still have to do all these other things to maintain your activity levels. So you're not going to be completely relying on, this medication alone to get you to your, healthy body goals. That being said, right, the amount that you eat might be less, but you should still be eating healthy things, and so you should still be eating at all. And I get that question a lot, sometimes about weight regain because of the concern with like, rebound weight gain after being off the medications or being on a long-term maintenance one. So if it makes you super hungry, it might be, if you're getting super hungry, it may be a time to reconsider your dose, first of all, but also to reconsider whether or not you are even eating enough at this point, right? And if you don't eat, you can't poop.
Thank you both. Yeah, great perspectives, very important points. One of the first questions that we got was from Kristen asking about the role of digestive enzymes for these patients.
Yeah, like we talked about earlier, sometimes going on a low FODMAP diet can be helpful. And then sometimes, certain enzymes that can help break down FODMAPs can help patient alleviate some of the symptoms that might be brought on from FODMAP. So it is definitely okay to try some digestive enzymes. Make sure, you choose one that is evidence-based, that is helpful, depending on what the patient needs help breaking down, right? If it's FODMAP related, then choose something that is FODMAP related. If it's fat related, then maybe choose something that can help with breaking down fats. But talk to the physician too about prescribing medications that can be helpful if it's, arises from other food tolerance related symptoms.
That's a good segue to another kind of stream of questions we were getting around gallbladder issues, and if you're seeing any fat malabsorption or complications related to gallbladder function with these patients.
So I am not. Dr. Fong, is that something you see, especially maybe in diarrhea cases?
That's funny. I actually have not. And I now that points out that I had a few patients where we did like actually investigate like, if there's any increased bile acids or any like liver enzyme abnormalities. And so far I haven't seen that. In fact, a lot of the GLP-1 agonists actually improve the liver enzymes because of their, use for like fatty acid uh fatty acid short chain fatty acids for fatty liver, right? So fatty liver disease, it actually improves your liver enzymes. I have not seen increased cholestasis.
Thank you, guys. Another kind of strain of questions that we're getting is about moving patients off the drugs. So dosing around titrating them off, any potential side effects, even the questions of will these patients be on these drugs forever? So if you both could kind of speak to maybe that question around moving off the drugs and what to expect.
Yeah, yeah. So I think that the problem with these with the GLP-1 receptor agonists is that we don't know yet. They haven't been around long enough for us to be like, well, can we ever get off get off of them for obesity and for weight loss indications. We've seen that in type 2 diabetes, patients tend to be on them long term, and over time they actually just, are on a maintenance dose, and that is, kind of like a forever thing. Unless there is a specific like type 2 diabetes where they've improved their nutrition, with diet and exercise, and their blood sugars are completely controlled. I have not seen where we're getting them off of it or like a titration schedule for getting off of it.
Well, I think this is where, continuing nutrition education is really important, maybe before, during, and after, especially for patients whose main goals might be managing diabetes or decreasing body weight, because we know, like what Dr. Fong said, GLP-1 is only part of the picture. We really want to maintain a healthy life. And if they've lost some weight, it encourages them to move their body more. That would be something, we really want to work with our patients on, to moving their body more and eating a more balanced diet, maybe more fruits and vegetables, which we can see they're really lacking in those two groups of food groups.
Thank you, guys. We also have a couple questions here on some of the GLP-1 marketed protein drink supplements and shakes. Would love to hear your experience or perspective on those.
Yeah, I think, for me as a dietitian, absolutely, if a patient is not getting enough protein, any way to help them get in, fill in the gap, make sure they're not losing lean body mass is really important. But, work with your patients, do other things first. If that doesn't work, protein shakes or, supplemental protein can be very helpful. And filling the gap, make sure they're not losing lean body mass. But if it persists, right, again, talk to the physician, or maybe talk to the patients about different strategies of getting more food in.
Great. We've also got some questions about kind of patients who may go from one spectrum to the other. So from diarrhea to constipation, or constipation to diarrhea, or who have IBS and actually on these drugs, their symptoms resolve. So we'd love to also hear your expert perspectives on what might be happening there and how to help these patients.
I would say, oh, no, you go ahead.
Well, I was going to say we've actually heard from patients and friends that their IBS symptoms resolved once they got on the GLP-1 receptor. I don't fully understand the mechanism, but I do think when you are reducing intake, that may be helpful for some patients because there is a reduced gastric load or reduced food going through your system. But that's, something very interesting. Yeah.
Yeah. No, I was going to say the same thing, which is that you're reducing your caloric intake, but the kind of fluctuation between constipation and diarrhea is common, and so therefore that should also be something that we counsel them. Like the one like major thing is that if you're going to have like diarrhea and then decreased food intake, once you've emptied it out of your system, you might have several days of constipation, and so that fluctuation back and forth is a very common kind of scenario. And again, like maintaining like a normal like food intake is generally what I think the most important part of this.
And I want to add to that as well, if a patient is fluctuating, right? This is where an osmotic laxative can be really helpful to make sure the patient is going to the bathroom every day and have a full evacuation. Maybe not every day, but maybe every other day, so they don't lead to a lot of stool burden, and then all of a sudden have a tremendous amount of diarrhea. So that's something, you can talk to your patients about, creating a bowel regimens, creating a bowel routine, make sure they are emptying properly, because that can also decrease a lot of the other symptoms like bloating, nausea, and maybe potentially vomiting as well.
Thank you, guys. Yeah, very, very fascinating. We're coming up on time, so I'm going to ask one more final question. And for anyone whose question wasn't quite answered, Jesse and Dr. Fong will share their contact information. So just to wrap up, we're getting a little bit of interest in choosing the right multivitamin, or when and if and how. So if you guys could maybe share your recommendations on multivitamins.
Great. I'll go first. We know in the US supplements are not regulated, and so third-party testing is really, really important. So you USP is one that I usually recommend patients look for, the logo of USP, or NSF for sports, or informed choice, or informed sports.
Mm,
I might be missing some, but then I think these three are the ones that I usually would recommend patients to look for when they are selecting a multivitamin. USP would be the most economical and most available label that you can find in big box stores like Costco or Sam's Club.
yeah, I think
Yeah.
there's not much I can add to that. I generally don't take a multivitamin, so I'm like the worst example. Don't ask me.
Well, I take one. And I want to say one more thing on the third party testing is because, it's purity, like it makes sure the medication
Yes,
or the supplement is
absolutely.
pure. It contains what it says it contains, because with no regulation, we really have no idea. And it doesn't have heavy metal contamination or maybe chemical or medications contamination in the supplements. So third party testing is extremely important. And as a dietitian, and as we are looking at the data, right, people are not eating enough in general. A multivitamin can be helpful. And again, bridging the gap, it's supplemental. It's not going to be the key, right? The key is still eating a balanced diet as much as a patient can, but we still want to at least bridge the gap at the baseline to cover some of the things. But we still want to do maybe periodic blood testing on high risk population to make sure that they are not truly deficient in things like B12, folate, iron, which these three are so important for our brain function, our red blood cell synthesis, and these can have long-term effects if they become deficient. So, and vitamin D as well. So getting tested on those things, get a baseline, and then test every 6 months or every year, depending on, your patient's population.
Great. Well, thank you guys so much for coming on. This has been fascinating. I hope everyone out there learned a lot as well. Thank you for your interest in this topic and joining us for the webinar. Thank you, Jesse and Dr. Fong, for sharing your expertise with us. And with that, we'll wrap up today's session. We hope to see you guys at the next one.
Yeah, and our information's on the next slide. So anyone who needs a slide deck, our emails are on there.
Oh, sorry, I should have moved it here.
Yep, there you
So
go.
I'll screenshot this. Well, it's in the deck, so you can
It's on the
find
deck.
us. Yeah.
All right, thank you so much for
Fine.
having us.
Thank
Thank you,
you.
everyone.
Bye.
Bye.